You're listening to He Said, a cardiology board review series. No fluff, just facts.
This episode is about the types of mitral regurgitation. We'll go over mitral valve anatomy, the systemic classification of mitral regurgitation, including the Carpentier classification, the presentation and physical exam, including auscultation findings. In the next episode, we'll talk about the severity and echo grading of mitral regurgitation, and in the following episode, we'll talk about medical management as well as intervention for mitral regurgitation. I feel this fully deserves 3 episodes because mitral regurgitation is one of the most complex valvular diseases. So let's start with the types. Mitral valve anatomy. The mitral annulus is a fibromuscular ring in the 2D shape of the letter D and a 3D shape of an elliptical saddle. The anteromedial part of the mitral annulus shares the same wall with the aortic annulus and is more rigid than the posterior annulus, so the dilation of the mitral annulus usually happens posteriorly. The posterior leaflet has 3 scallops, from lateral to medial, the anterolateral scallop, which is P1, the middle scallop, which is P2, and the posterior medial scallop, which is P3. P1, the scallop that is closest to the left atrial appendage laterally, is the smallest scallop and rarely prolapses. P2 is the largest scallop. The anterior leaflet has 3 segments. From lateral to medial, the anterior segment, A1, the middle segment, A2, and the posterior segment, A3. The anterior leaflet does not actually have true scallops, but is arbitrarily divided into 3 segments for practical purposes to match the 3 scallops of the posterior leaflet. Remember that the aortic valve is anterior to the mitral valve and they are joined by the aortomitral curtain. The coronary sinus runs along the posterior aspect of the mitral valve from P3 to P2 to P1. Now let's move on to the systemic classification. Mitral regurgitation is classified by whether it's primary or secondary, Carpentier type 1, 2, or 3, and acute or chronic. Primary refers to abnormal leaflet or chord, whereas secondary refers to situations with normal leaflet and chord. Carpentier type 1 refers to normal leaflet motion, type 2 is excess leaflet motion, and type 3 is restricted leaflet motion. Let's see what all of this means. In type 1 MR, the leaflets have normal mobility but poor coaptation due to annular dilation or perforation or cleft or indentations of a leaflet. Leaflet perforation or leaflet cleft, which are considered primary MR, can result from endocarditis, congenital malformation, or iatrogenic trauma. Atrial and annular dilation, which are considered secondary MR, are associated with chronic atrial fibrillation or HFpEF, resulting both in progressive modeling of the LA. Increases in LA pressures result in annular dilation and flattening. The leaflets may try to remodel or thicken, but in such a way that exceeds the increase in mitral annular area. These processes will result in disruption of normal leaflet coaptation mechanics. Notably, in type 1 MR, there will be normal left ventricular dimensions, papillary muscles, chordae, and leaflets. In type 2 MR, there will be excessive motion of the margin of a leaflet segment above the annular plane. There is leaflet redundancy. Type 2 MR is almost always a primary MR. The 2 classic types of type 2 MR are mitral valve prolapse and leaflet flail with ruptured chordae. These 2 examples of type 2 MR can happen in myxomatous disease or fibroelastic deficiency, which are both instances of degenerative disease. Myxomatous disease, which occurs in young patients, is when the mitral valve has cellular proliferation, increased matrix production, and resultant thickening of both leaflets involving multiple segments. In myxomatous disease, the mitral annulus is dilated, and the largest mitral annular area occurs in late systole, so it will be a late systolic MR. Myxomatous disease also has early loss of early systolic area contraction that also contributes to leaflet malcoaptation. In fibroelastic deficiency, which occurs in older patients, thickening occurs on a specific fail segment, typically the posterior, especially P2. In fibroelastic deficiency, leaflet area remains constant throughout the cardiac cycle and the mitral annulus does not get dilated, unlike in myxomatous disease, so it will be a holosystolic MR, unlike the late systolic MR of myxomatous disease. In type 3 MR, there is restriction in leaflet mobility, resulting in coaptation of leaflets while they are at the ventricular level. Type 3A MR is restriction in leaflet opening, so the restricted leaflet motion occurs in both systole and diastole and is considered a primary MR. Type 3B MR is restriction in leaflet closure, so the restricted leaflet motion occurs in systole only and is considered a secondary MR. Type 3 MR, which is the restriction in leaflet opening, results from rheumatic heart disease, carcinoid disease, radiation, or mitral annular calcification. The aforementioned entities all have thickening, retraction, and rigidity of leaflets and attached chordae, thus restricting both systolic and diastolic leaflet motion. Type 3B MR, the restriction in leaflet closure, results from conditions which lead to displacement of the papillary muscles away from the mitral annulus and systolic tethering of the mitral leaflets transferred to tens chordae tendineae, which can be seen in ICM or DCM. Note that type 3B MR has intact leaflets, just like type 1 MR, except leaflet perforation and cleft. Systolic anterior motion mediated MR and HCM does not fit within the Carpentier classification. SAM-mediated MR is typically posteriorly directed, occurs in mid or late systole, matching the time of obstruction, and varies with outflow obstruction. Some people label SAM as Carpentier type 4 MR. Now let's talk about the two main types of degenerative valve disease. As I mentioned earlier, the two main types of degenerative valve disease are Barlow disease and fibroelastic disease. Barlow disease, which is an infiltrative disease of the valves, involves excessive myxomatous tissue due to accumulation of mucopolysaccharides in one or both mitral valve leaflets and sometimes chordae. The leaflets thicken, become bulky, and lead to redundant valvular tissue with redundant billowing leaflets. The chordae frequently elongate or rupture. This is usually diagnosed in young adults who present with bileaflet and multisegmental prolapse, sometimes with flail scallops. They are followed with serial echo over decades until indications for surgery are met in their fifth decade of life. In contrast, patients with MR from fibroelastic deficiency are usually in their 60s and present with a short history of localized or unisegmental mitral valve prolapse or flail. Fibroelastic deficiency is an acute loss of mechanical integrity caused by abnormalities of connective tissue structure or function or both. Only one segment should prolapse or flail, although multiple chordae can be affected. Fibroelastic deficiency is the most common organic MR for which mitral valve repair surgery is needed. Remember that both Barlow disease and fibroelastic deficiency, which are instances of degenerative mitral valve disease, belong to type 2 MR as they are disorders of excess leaflet motion. Marfan syndrome and Ehlers-Danlos are other instances of type 2 MR having excess leaflet motion. A few other tidbits about MR types and imaging. In acute severe MR, rapid equalization of pressures between the LV and left atrium may result in a short, unimpressive murmur. Infective endocarditis can cause MR through multiple Carpentier types. The murmur of acute severe mitral regurgitation due to papillary muscle rupture is unimpressive or absent due to rapid equalization of LV and LA pressures with a little pressure gradient. CW Doppler will show a triangular-shaped dense MR signal. In contrast, the development of a pulsed MI VSD will have a loud systolic murmur even when it is acute. Ischemic mitral regurgitation usually has a posterior regurgitant jet, posterior leaflet tethering, and anterior leaflet override. Ischemic MR is a disease caused by changes in LV structure and function, in contrast to rupture or stretching of the papillary muscle. 50% of post-MI patients will have ischemic MR without papillary muscle rupture, of whom 12% are moderate or severe. The presence of moderate or severe ischemic MR carries a threefold increase in the rate of heart failure and a 1.6-fold increase in the risk of death at 5 years. In a majority of ischemic MR, posterior leaflet restriction with a resulting anterior leaflet override leads to a posteriorly directed mitral regurgitation. Sometimes ischemic MR can have LV enlargement tethering both mitral leaflets and creating a more central jet. Flail mitral leaflet results in asymmetric coaptation and a severe eccentric jet that is directed away from the affected leaflet. mitral annular disjunction, which can be seen in myxomatous degeneration of the mitral valve or mitral valve prolapse, is defined as a separation between the left atrial wall at the point of mitral valve insertion and the left ventricular free wall. The presence of mitral annular disjunction is associated with increased degeneration of the mitral valve and increased incidence of sudden cardiac death. Mid-systolic billowing of the mitral valve more than 2 millimeters above the annular plane is characteristic of mitral valve prolapse. In mitral regurgitation, if there is posterior leaflet prolapse, the MR jet would be expected to be anteriorly directed. Now let's talk about presentation and physical exam. We'll talk about the auscultation of mitral regurgitation and the auscultation of mitral valve prolapse. In mitral regurgitation, the murmur is holosystolic, extending from S1 to S2. The character is plateau-shaped, it is heard at the apex, and it radiates to the back or axilla if it is a posterior MR jet, radiates to the left lower sternal border if it is an anterior MR jet. The intensity of the MR murmur is proportional to the pressure gradient between the LV and the LA during systole, and the MR murmur increases with hand grip because that increases the afterload. Now, auscultation of the mitral valve prolapse. The timing of the mitral valve prolapse is a mid-systolic click plus a late systolic murmur. The late systolic murmur may be absent in some patients. Both are heard at the apex. The click can also be heard at the precordium. It indicates one or more mitral leaflets that are displaced at least 2 millimeters from the mitral annulus into the left atrium on echo from myxomatous degeneration, elongation, and subsequently chordal rupture. The mechanism is as follows. As blood flows retrogradely from the LV to the LA, mitral valves maintain themselves at first, but then chordae tendineae suddenly prolapse and tense up, which you hear as a mid-systolic click. Maneuvers. Maneuvers that reduce the LV volume, such as Valsalva or standing, which decrease preload, cause the mitral valve to prolapse into LA sooner, pulling the click forward from mid to early systole and increasing the duration of the systolic murmur. Conversely, maneuvers that increase impedance to LV emptying, such as hand grip, which increases afterload, or that increase LV volume, such as squatting, which increases preload, will cause the mitral valve to prolapse into the left atrium later, pushing the click from mid to late systole and shortening the duration of the late systolic murmur. That's all we have for mitral valve anatomy, types and systemic classification, and presentation and physical exam. Tune back into the next episode where we'll go really in depth to grading severity of mitral regurgitation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.